Well, Dr. James Kramer from Murphy Wainer Orthopedic Specialists at Murphy Wainer today on a Friday, getting close to holiday time, so people are going to relax a little bit. But you can never relax in your business, always busy. Right now we're in baseball season, so I thought we'd pop up a baseball thing first. What about, Dr. Kramer, what about I always hear about this hamate bone injury for baseball players. What is that?
Yeah, so the hamate bone is a bone in the wrist, and it is an injury that occurs in baseball and also in golf. Those are the two sports that I tend to see it in. In baseball, what tends to happen is a guy, while they're batting, they'll check a swing, and there's torque to the wrist, and it's a small little bone in the wrist, and it has a little hook to it, and that hook or beak of the bone gets fractured or injured, and it's a source of persistent wrist pain. And it can be frustrating for professional baseball athletes or any baseball athlete because it tends to not heal. And so when we recognize that injury, it's a source of pain. Oftentimes we just have to take that little beak or hook of bone out because of poor healing of the bone. So there is a fix to the problem, but it typically requires surgery to resolve that. So it's a pretty specific injury that we see to baseball, and it almost always occurs while batting.
Yeah, I've always heard it's been like a small bone, but a huge problem.
That is correct. Small bone with a fix when it gets injured, but the fix is a big step to take. So you're exactly right.
What about the UCL injury, the ulnar collateral ligaments becoming a problem too, I think, for a lot of players?
That is correct. So that's also a very sport-specific injury, particularly to baseball. The ulnar collateral ligament is a stabilizing ligament to the inner side of the elbow. And so it's specific, very localizing to the elbow and to pitchers. So for people who have never seen a slow motion video of a pitching motion, it's worth watching because the amount of stress on the inner side of the elbow that occurs in a throwing motion is significant. And what happens is that ligament gets undue stress and it can actually tear. And when that injury occurs and you have a torn ulnar collateral ligament, it lends itself to chronic pain. The elbow doesn't work properly. It's incompatible with throwing a baseball at any kind of high level. And so most people have heard of the Tommy John surgery. He was a professional baseball pitcher with the Los Angeles Dodgers many moons ago. He was the first professional baseball pitcher that had that injury where it was then repaired and he got back to being able to pitch at a professional level. Prior to that, when that injury occurred, most pitchers, their career was done. So we see it in high-level baseball pitchers, but it's also becoming more and more prominent now in younger athletes, even in the 13, 14, and 15-year-old age group. So it's a pretty significant problem in baseball, young and professional, and it's an issue with the elbow.
And that'll put you on the shelf, as they say, probably some of those pitchers at least a year, right?
Correct. So, for instance, if a professional baseball pitcher has that injury and they have surgery to repair it, it's a year recovery. Yes.
What about, you look at that, I've always heard to talk about taking a part of a bone from another part of the body and replace it to another part of the body. Do they do that with the Tommy Johns, or is that done with other injuries?
Not so much with Tommy John. Tommy John is it's a soft tissue injury. It's a ligament, so there's no bone grafting or any kind of bone repair for that particular injury. We do that in other things.
So that's the problem sometimes too. You can take the part of a bone, another part of the body, and put it in another part. You can replace that.
You can. That is done at times for certain things, yes.
Other baseball injuries we could talk about, ones you could think of, those two hit my mind first.
Well, hamate, wrist, elbow, UCL, and the other most common thing that we see all the time is shoulder injuries. Right. Again, it's a pitching-related phenomenon. So a baseball pitcher, again, lots of stress when they're throwing a baseball to their shoulder, and so shoulder injuries, rotator cuff problems are also very common in baseball in throwing athletes, particularly with pitchers.
I guess they talk about the torque, the amount of torque.
Absolutely. It's the amount of torque, but it's also the repetitive nature of what they're doing day in and day out. When you have a repetitive biomechanical stress to the tendon deep in your shoulder, it gets irritated from overuse.
Let's go to some other injuries to other sports. Maybe right now soccer is pretty prevalent these days. I was at a soccer game last night with Paige over at Paige High School, and I know Lindsey Braddock from your crew was over there working on those Paige kids, doing a heck of a job. What about with soccer, since we talk about MCL and ACL injuries, sometimes those players, other sports too, but since it's soccer season, I thought we might mention those kids there.
Sure. So the types of injuries you tend to see in soccer tend to be lower body injuries, whether it's ankle or, as you mentioned, MCL, ACL, or ligament injuries to the knee. So there are 4 stabilizing ligaments to the knee. The MCL is the inner ligament. The ACL is the one that you hear and read about on TV, on ESPN, athletes who have ACL injuries. It's a devastating injury, whether it's a high school age population or professional athletes, because when that inner ligament gets hurt and torn, it does not heal and it requires surgery. And similar to the elbow dilemma we talked about, it can take 6 months to a year to have complete recovery to get back to play. So ACL, MCL, knee injuries, common in soccer for sure.
I hear a lot of times about athletes, they'll tear the MCL, they'll come right back, maybe tear the ACL right after they come back from rehab and recovery. Are those injuries sometimes put more stress, more strain on each other and cause the other to go bad too?
The correlation between the two typically happens when, if you have an MCL injury, you do appropriate rehab and therapy, you try to get back to maybe play a little sooner than you should, your knee's not quite strong, you're a little bit hesitant, and in doing so, that increases your risk of injuring the knee again or in more significantly. So it's really not directly correlated, but they're indirectly related, just because typically there's some semblance of loss of strength, there's a semblance of favoring it, and so when that happens, you tend to tear or hurt the knee again, and more significantly.
Yeah, we hear a lot of times that these are successful, some are unsuccessful, and there's a lot of stress, a lot of strain on those knees. But a guy like, I think, Thomas Davis, Carolina Panthers, I think he had like 3 MCL injuries, and he kept coming back. He finally got back and had finished to his career very successful.
Correct. So even though those injuries are serious and are significant, with appropriate rehabilitation and appropriate treatment, those injuries, either or, surgery or not, the vast majority of athletes get back to the level of play they were accustomed to, whether it's recreational or professional. And so in this day and age, even though those injuries are serious, we can appropriately treat them, manage them, and get athletes back to their level of play they're used to.
But like you say, maybe 30, 40 years ago, if they tore the UCL or tore the MCL, ACL, their career is probably over.
Correct. I mean, particularly ACL injuries, which is the common thing you see not only in soccer, but let's say basketball and or football. In the old days, we used to call it a trick knee. When somebody would tear their ACL, it would never heal. You had a knee that would give out or give way, and so back in the old days, we called it a trick knee. And so absolutely, they were career-ending injuries back in those days.
Dr. Kramer, let's switch gears and maybe go towards your work with the local teams over the years. Greensboro College, quite a few years working there, and a lot of years with the Dudley Panthers over the seasons.
That's correct. I've been working with Dudley High School since 1990, and I've been working with Greensboro College really since 1993, so the early 90s with both of those institutions.
So Dudley, you've been with all those 3 state championships with Coach David Price. You were with all those championship teams then?
That is absolutely correct.
What about, here's an interesting one before we go back, maybe you may remember this, maybe not, but there was a game probably 20 years ago when Dudley was, maybe 15 years ago, when Dudley was playing Word of God on a Saturday night. P.J. Harrison got hurt. When P.J. Harrison got hurt, it was like a dramatic scene. Always when he got injured, it looked like it was much worse than maybe it actually was. But you took him back at halftime. When he left the court, looked like he was about to die. You took him back at halftime. He came back out second half. It was like he'd been totally repaired, renewed. What kind of injuries did you see with him back in those days? How did you get those fixed up so quick?
Well, a lot of times, particularly in higher level athletes, sometimes something happens to them. In the heat of the moment, there's a lot of emotional distress. It's a big game. A lot of times there's a momentary sense of panic. And so if you remove the athlete from the situation, in that situation we go to the locker room, assess the injury. Oftentimes it's relatively minor. A lot of times it's simply reassurance. It's in letting them know this is nothing serious. You do some simple little basic reassuring messages. The athlete then has a clear sense of mind, and they're able to go back to compete without this fear of, am I really injured or hurt? So in that situation, nothing serious. It was simply a reassuring message, and he's able to get back and play, and he did absolutely fine.
Here's something you did a couple of times over the years. I would see you test the athletes to see if they're ready to go again. I mentioned to you this one time, maybe a few years back, but you pulled out something like a tuning fork and popped that tuning fork toward their knee or something. What was that? Was that testing calibration? What was that testing?
So a tuning fork test is an old school way to basically, when you pop the tuning fork, and we typically use it along the shin bone. If somebody has a shin bone injury and we're concerned about bone trauma, when that tuning fork, when it's vibrating, when you put that on a bone, if there's a bone injury, for instance a fracture, it really significantly increases pain through that bone. And so it's an old school way of trying to determine whether or not there may be a fracture. Now we have portable on-site ultrasound units, and so with an iPad, with an ultrasound transducer, we can put the ultrasound transducer on the bone and see if there's a fracture. So the tuning fork is not in my armamentarium anymore. We actually have significantly much better technology, and we actually use an ultrasound now on the sideline.
You had a lot of success, I would say, probably with Dudley over the years. You had Peach Harrison, William Graves. They had a ton of outstanding athletes, but I never saw too many of those guys get injured and be laid up for long periods of time. Maybe it was some luck, maybe it was the good care, but they were never down and out for long periods of time, it didn't seem like.
Well, that's true to some degree, but you remember Eric Hicks?
Oh, yeah, I remember, yeah. Those knees,
he had a devastating knee injury.
Yeah, I remember that,
So he is an athlete who had an ACL MCL. Mm-hmm. He did have surgery. It took him a year, but he was able to get back from that injury. He went on to a very high-level college career, and then he ended up playing in Europe for several years. So
exactly.
There have been, significant injuries over the years. Fortunately, not a lot, but they do happen.
Yeah, Eric Hicks, he was in that Burlington Williams game at Williams, and they tried to get East Carolina,
correct.
and then it was all blown out there.
Right.
Yeah.
That's exactly right.
They called him the helicopter back in the days, I think.
Exactly.
He was a good one, no doubt about it. What about, to switch the gears again to the adults, what about the problem? Because I've seen it among myself and among relatives, among friends. What causes the onslaught, the introduction coming to our bodies? What brings this arthritis to our bodies? What causes this?
So there's really two things to think about when we talk about osteoarthritis, which is aging-related wear and tear of a particular joint. Let's just say your knee. So some of it is just simply getting older, and over time joints do break down as we age. So sometimes it's simply the aging process that may be complicated or exacerbated by a certain genetic or family history propensity. The other thing is, it's been shown if you do have, let's say, a knee injury, let's say in college athletics you have a knee injury or you tear your ACL, even when you have surgery, over time, since that knee has been injured, it doesn't work the same as it had before. And so that also increases your risk of developing degenerative arthritis as an adult. But ultimately, osteoarthritis is simply an aging process, and it's extremely common. We see lots of elderly folks in our practice, and so osteoarthritis, whether it's of the knee, the hip, the spine, it's a very, very common problem that affects all humans.
Is there such a thing as an arthritic or arthritis attack? Sometimes I've had the hands, the arthritis comes in almost strong and severe, painful, then all of a sudden after a period of time it's gone.
Yeah, sometimes that happens. So if you have let's say an arthritic joint, let's say if you have a bad hip and you can do okay with that. Let's say you decide to go for a big hike. And all of a sudden you're putting more stress on the hip that it's not accustomed to. It gets flared up. After some relative rest, it calms down. So that sort of cyclical, gets irritated, calms back down. It is pretty common. That's pretty typical when people have arthritic joints.
How do you treat arthritis?
So staying active, number one.
So as long as you keep moving, that
correctly.
helps.
Inactivity makes joints stiff. So
Gotcha.
staying active is probably the key. A lot of people use over-the-counter liniments like BioFreeze. You may have heard of Voltaren gel. It's an over-the-counter anti-inflammatory cream. Aleve, ibuprofen, those medications over the counter. So whether it's simple over the counter medications, whether it's topical liniments, and staying active, those are the simple things. When it gets more problematic, physicians can prescribe arthritis medication. Sometimes we'll do cortisone injections to calm down inflammation. And then ultimately, for certain joints like the hip or the knee, if it's bad enough and it's causing disabling symptoms, we ultimately do joint replacement surgery.
Gotcha. What about, I'll close it out with this one today, what about a pinched nerve in the neck? How do you alleviate that? How do you stop that?
So a pinched nerve in the neck, common. There's a couple ways to manage that. One are strong anti-inflammatory medications. Oftentimes we'll simply use a course of oral steroids or prednisone. Sometimes simply taking the medicine can calm it down. Oftentimes we'll do physical therapy. A physical therapist can do traction, which is basically trying to alleviate the pressure on the nerve with some therapy modalities and traction. And if that's not effective, oftentimes we'll do a steroid injection around the nerve to again lessen inflammation. If none of that's effective, ultimately surgery can be done to take the pressure off the nerve, although that's the last resort. And in our practice, we tend to do medications and physical therapy, and then sometimes injection therapy can be helpful.
Can something like that lead to more arthritis?
Not necessarily, no. You can get a pinched nerve in your neck from two fundamental things. One is simply having a bulging or ruptured disc, which is the cushioning between the bone blocks. The second cause is when you do have arthritis and you develop bone spurs. Those bone spurs can irritate the nerve and cause nerve inflammation. But a pinched nerve doesn't really lead to arthritis, no.
What about a lot of popping? Should there be a lot of popping involved with that when you have that pinched nerve?
Popping occurs when you have arthritis, because what happens is your body tries to protect itself, for instance in the neck, with muscle tightness. So that popping or feeling like you have a crick in your neck or neck stiffness, that's all muscle inflammation and soft tissue inflammation. So that's typically seen when you have arthritis. Sometimes when you have a pinched nerve, but that's more typically seen when people have neck arthritis and have kind of chronic neck pain.
And you treat that the same way pretty much with the over-the-counter appointments and things like that?
Yep.
What's the most prevalent injury or type thing you see in your work? I know you see all kinds. What do you see the most of over here, probably, as far as what you treat or work with?
In elderly adults, it would be arthritis, whether it's of the spine, the hip, or the knee. In the active population, we see a lot of shoulder, knee, and ankle injuries. That's predominantly what we're seeing in the active population when people have injuries.
Here at the Murphy Wainer practice, what's the easiest way to get in touch with you?
The easiest way to get in touch with us would be to essentially call our office, 336-375-2300. That's our office number. The girls are always amenable to answering the phone. You simply call, ask for me or whichever physician in the practice somebody prefers. Make an appointment. We're readily available. We pride ourselves on doing acute care work-in patient clinic office visits. So we're always happy to see people same day or next day at the latest when people call to make an appointment.
Dr. Kramer, thank you for your valuable time today. It's been a pleasure talking to you. You've answered these questions with a lot of expertise. Appreciate the good work, and always good to see you out in the community helping the people and serving the community well. Thank you so much.
Thank you so much, Andy. Appreciate it.